And my other co-chair, Christine Apple, will be joining us later. And Christine is a psychologist with the Department of Corrections. And as far as a few meeting logistics, Barbara will go over the ground rules for the meeting.
All right. Would you like me to go ahead, Mary?
Yes, please.
Great. Welcome, everyone. Barbara Beckert here. Just a few ground rules to help our meeting run smoothly. We ask if everyone can please stay muted to eliminate background noise. That's really helpful. We have given our first two speakers some questions in advance. It's possible that there will be time for a few additional questions, but we're not sure. If we don't have time, we'll get them to the speakers, but please put your questions in the chat and I will collect those so that we can ask them if there's time or share them. We are also have ASL interpreters available. So if you need any assistance accessing the interpreter, put that in the chat. Speakers, if you can say your name before you speak to help with accessibility, we appreciate that. We also have auto captioning. You can just click on the show captions to turn that on or off, whatever you prefer. And I think that that's our logistics for today. All of the materials are on our website, so you can view them there, and I will put that link in the chat. And I will turn it back over to Mary.
Okay, just a reminder, as far as the Mental Health Task Force annual membership drive is currently ongoing, and our goal is to hopefully wrap that up by the end of the year. That is our goal, and that is for membership for organizations and individuals, and those materials are on the website. And if you have been an organizational member in the past and you would like to continue to be an organization to support the Mental Health Task Force and all the efforts and advocacy and education we do that Kathy Eiler spoke about a couple of meetings ago, please go to the membership details. You can now become a member via check or credit card. That goes for individuals as well. Whatever you can contribute is greatly appreciated. And if you are with an agency and you have a check in process, if you could either contact Barbara via email or myself and let us know that you have a check in process, that would be helpful. And so that is our membership campaign that is ongoing. And just a piece of information for our January 10th. Karen Avery Forum recap. Barbara, are you going to do the recap, or is Pete going to do that?
I think Pete Kniesny is here. Pete, would you be willing to just say a brief message? We're so grateful to you and the team that put this together, and I know you have plans for January to mention.
Yes, let me turn on here.
Thank you, Pete.
I didn't prepare anything. I wasn't aware of I'd be doing this, but that's fine. The forum on the Karen Avery forum I thought was well received, and it featured the director and the advocacy training director for Rise magazine out of New York, and they gave a perspective on their work with parents involved in child welfare system or child protective services, and they shared their personal experience, lived experience with those systems, but also talked about the value of peer support and community support and resources support as critical to avoiding harmful separations of parents and children. And I think it's still available to watch, and I'd recommend it. The second half, second panel was same idea of listening to the voice of parents as to their needs in child welfare circumstances, and that was Chief Judge Trigiano of Milwaukee County, who had been the judge for the drug treatment specialty court at Children's Court, where cases that are otherwise in the CHIPS and termination of parental rights docket, if there was mental health, drug or substance abuse issues involved, could have a very different approach, very more wraparound, holistic, involving the parents as a team in resolving their problems. And we heard from two veterans of that program and relating their experience and their appreciation of the direct support they had in that model of approach. And both of those individuals have gone on to have professional jobs working with other parents. So I think it was a very valuable hearing from people close to the experience of a family in child welfare. And then we're going to build on that or follow up on that for the January 10th Mental Task Force meeting with programs in Milwaukee that work in support of parents' needs directly, with the idea of avoiding undue or prolonged separation of parents and families through peer support, through providing resources and other models in which they avoid separation in order to preserve that essential bond between parent and family, rather than using foster care, which has traumatic and other damaging developmental impact, particularly regrettable where that wasn't absolutely necessary because of imminent risk to a child in the home. So that's going to feature Brigetta Wilson, who's I think parent empowerment coordinator for the Department of Children and Families, representative from Maida House, their model for supporting parents. The Benedict Center, which works with women and often in a parental situation, and like who else I'm missing here? And Community Advocates, which is a recent grant to actually work with at-risk families and providing those essential housing and other resource needs that are often a big part of what happens in a challenged family situation that often leads to bad results in the child welfare system. So that's where we are right now. So it's going to be more people working with people in the system, and the successful models that are empowerment-based or strength-based models to get away from the prosecutorial approach that sometimes prevails in child welfare cases that go through the court system. And then we're going to follow up in February with looking at systemic issues affecting child welfare.
Thank you so much, Pete.
Okay, go ahead.
That was really a great recap, and stay tuned and save the date for January 10th. We've got a really exciting lineup to follow up on the forum, and really appreciate the work of Pete and the committee.
Thank you, Pete. And so I'd like to move on and introduce Kevin Kluesner. And Kevin is the site administrator for the Mental Health Emergency Center. And Kevin is going to present us with an update. Welcome, Kevin.
Hi, Mary. Thank you for inviting me today. Just hoping you can you see my screen?
No.
No. Okay, hold on one moment. Let me see what else I have to do here. I thought I hit share, but okay, hold on. We're getting there. Give me one more second.
Absolutely. And if you need a hand, just let us know. We are ready to assist.
I know, but I feel such a,
We've all been there.
I've got my piece up and I'm trying to share, but some reason. All right, one last thing I'm going to try here. How about now?
There we go.
Success.
You're up.
All right, okay. So I'm going to run through just some statistics which will answer some of the questions that were raised. And I'll go through it and you'll see that the numbers are still somewhat preliminary. I mean, we're still working with our system. We pull them out of Epic, which is the EMR that all the health systems use, which is kind of a good thing.
Yep, you're not in slideshow though.
I have a slideshow up.
Are you supposed to be in slideshow?
Well, I have I can do that, hopefully. You want it?
There you go. Okay.
All right. Can you see this?
Yes.
Okay. So part of my screen is taken up with something else, but so I'm giving you a 2-week snapshot. This is the latest 2 weeks that we pulled up. So it's from November 13th through the 26th. And we kind of look at this every couple of weeks. So that was actually our lowest 2-week total. We saw 244 patients in that 2-week time period. 39 were children and adolescents, 205 adults. When you look at the legal status at admission, you'll see that so it was about 55% in this given 2-week period came in as involuntary. Legal status at discharge, you can see that changes quite a bit. So when our physicians have a chance to work with the patients, they're dropping a lot of those Chapter 51s. The mode of arrival, and I'm going to show you a slide that shows, it's kind of an interesting phenomenon, and I don't know if it's what's behind it, but you see that 202 of these patients were brought in by law enforcement. So obviously a lot of them voluntary patients that law enforcement has picked up and they brought to us. 39 by self, that's obviously could be themselves, loved ones. And then the ambulance is only 3%. And I think a lot of those are people coming back after we sent them out for medical clearance. And then the discharge locations, you can see home community, inpatient psych, and then the other. And we're still trying to tease out some of this, like what exactly is under that other, so that we know exactly what is going on here. So that's what I'm saying. I'm not saying this is like perfect information, but this far into it, it's not too bad. So these are the patient volumes at MHEC, and these are 2-week periods, and it ends. So this is for October 1st. So you guys remember, we opened up for voluntary patients on September 6th. We opened up for involuntary on the 9th. And so this really starts kind of from that last half of September. So almost since we opened up until close to the end of November. And you can see here, our total have ranged from 258 patients in any given 2-week period, a high water mark of 285, and then down to 244. And the kids ranging from about 37 to 56 in any given 2-week period. This is that interesting one I talked about. That first couple week period, it was almost 50-50 patients coming in by self or coming in by law enforcement. And I'm not quite sure what's behind this, but it has been almost linear in terms of the growth. And then it's bounced up and down a little bit in terms of patients coming in by themselves. And then ambulance, I think the most we've ever had in any given 2-week period has been 6, and it went down to 3 there. And I think this might be my last slide, but this shows you guys had asked for discharge location by hospital. And so I kind of showed that. When I show here the 21st, in 3 of the 5 2-week periods that we looked at, Aurora actually received more of our patients than anybody else. And when I say Aurora, it's 90% Aurora Psych. It's a little bit might go to South Shore, but it's mostly Aurora Psych. And then the next is Granite Hills. And you can see that 2 of the 5 periods, they took more of our patients than anybody else. We saw kind of a big jump when they opened up their adolescent unit, because these first 3 2-week periods, they couldn't take any of the adolescents. So that did help, I think, quite a bit. And then you see after that, it's different. What we saw originally was that Rogers took a surprising number of patients, and maybe it was because there wasn't the ability, and they stepped up with Granite Hills not able to take those adolescents. That has seemed to taper off now. The blue is Winnebago, and you see that kind of popped up to 6 and has tapered back off to 3. And I think that gives you a pretty good snapshot. And I'm going to stop sharing, and I'm going to walk through your questions to the best of my ability, and then you guys can decide. I see a question. What about the Dewey Center? The Dewey Center, so they might get some of our patients, just like we send them out to other places. I'll get into that. I apologize. How many people are being seen at MX? Right now, with those numbers that I showed you, it's annualizing out to about 7,000 a year, which would be, I don't know, it wouldn't be quite 1,000 more than what PCS was seeing before they closed. And I think that says something about when everybody was designing this and where it should be cited. I think you guys did a pretty good job. I mean, we knew that about 93% of the patients that were going to PCS were coming from Milwaukee, and over 70% were coming from 53205, which is our zip code where I'm sitting today, where MHEC is, and the contiguous zips. So I think that was spot on. How many are adults? How many are juveniles? It's roughly 17% are kids. So, and they've been younger than 12. So, but most of them are adolescents. How many of these are involuntarily detained? It's roughly 50% right now coming in. And I showed you that idea. It's quite a few less when they're discharged. How many are sent to a hospital, and break that out by hospital? I did that. It's about 18% are discharged to mental health beds. We talked about how many sent to Winnebago. And since the September opening, this is a good question. How has MHEC had to close or to be on diversion? And if so, why? And I say we've never closed, and we never will close. We're a mental health emergency center. So we did go on diversion to law enforcement twice. And one time was on November 11th, and that was for a total of 6 hours. The other time it was on the 14th, and that was for a total of 4 hours. So if you take the number of hours that we've been open, that's roughly 0.4% that we diverted law enforcement. And at that time, we were still open for those patients that were voluntary, just coming up to our doors. And the thing I tell our staff is, when we've done that, and it's because we had so many patients here, and we had patients without boundaries, and we did it because we felt like for that short period, patients would be safer being diverted to medical EDs. And the other thing that we're doing there is, when we're diverting involuntary patients to those medical EDs, we know that they're going to come back to us when we open the doors back up to law enforcement. And so it's just a temporary kind of, let's try to settle down the house. Let's get it to where we can safely take these patients. And, hopefully that's a pretty good answer on that. How long are people waiting at MHEC for a decision as to whether or not they are going to be involuntarily detained? It's always less than 24 hours. We want to do it as quickly as possible, but our physicians want to make sure that they understand completely. Sometimes patients have to settle down a little bit and have a little bit of treatment before they want to make that decision, but it's always less than 24 hours. If involuntarily detained, how long are they waiting for a bed to open up? We believe this process was going to be no more than 23 hours. This is variable. I think everybody understands that we need some more mental health inpatient bed capacity. But, I believe everybody's working right now in this community to try to make that time frame as short as possible. And one of the things I wanted to call out is we've been meeting with Milwaukee County BHS with Mike Lappen, Linda Oshus, Dr. Schneider. We've been meeting with Granite Hills. We've had a group meeting with APH for months before we opened, every week. And we've been meeting every week since we opened to make sure that we're doing the best job we can at moving people through this system of care and getting them to the right places that they have to be. The question was raised, how many people are being seen who have co-occurring developmental or intellectual disabilities? And is there staff who have expertise supporting people with IDD? And has there been coordination with family care, managed care organizations? And this answer is there's absolutely been coordination. Typically, that coordination is taking place by our nurses. We have social work, and that was one of our issues when we first opened. We didn't have social work. This is a very tough time to recruit. We've done a great job with nurses and techs to where we're pretty much fully staffed. But when it came to social workers, we were having a hard time filling that. We've been able to fill that now. And between the nurses, the physicians, and social work, we are working closely. But this is an area we have to get much better at. Connection to services, that goes back to what I was just talking about, connecting people in the community. We have great resources out there. And I think our physicians, nurses, social work are doing a good job of connecting people. I think we have to do it more quickly at times. And I think we're working with the Milwaukee Healthcare Partnership, with county, with others, to make sure that we really fully understand the wide array of services. And also, when we're trying to make a connection to people, there are times that there are barriers in the way. And one of the things we're doing is, I think we're kind of a set of fresh eyes. When we see barriers, we're trying to bring those forward to say, I'll give you an example. I met with the people from Lad Lake who provide crisis stabilization housing for female adolescents. And, I'm basically saying, because I've personally been on the phone trying to make connections for staff or for patients. And it's kind of like you have to get the parents to get their authorization. Then there's like 2 more steps in that process. And a lot of times it's hard for the parents. They have issues in terms of how it's hard for them to get out and do different things. And one of the things Lad Lake said was, well, what if we provided DocuSign? Would you work with us, and could we work with the families to make that? I'm like, we'll do anything that makes sense, that makes this easier to get the patients to the right level of care. So I think we're seeing opportunities out there where we can break down some of the barriers for families and make it easier. Communication. There were recently some confusing rumors about MHEC closing. It turned out there were a few hours when MHEC was closed to involuntary patients. Who's the best point person in the future to verify this type of information? about MX services. And I would say my commitment is, I want that to be a never situation, but it may happen again. My commitment is I'm going to let Mike know right away at BHS. But I have no problem if people call me from the community and ask me questions. I got questions from a number of people, including law enforcement, some of the legal community, and I answered them as straightforward as I could. We want MHEC to be successful. What do you see as the biggest challenges, and are there opportunities for community agencies to be a resource? Absolutely. And are there resources about MHEC that we can help to share with the community to provide education about the role of MHEC and encourage use of other community resources, such as the access clinics? Yes, I think there are. And, both Mike and I were just interviewed for a question about this issue by I think it's the Milwaukee Neighborhoods, that publication. It's out of kind of overseen by Marquette. And, one of the things we talk about is MHEC is really for people that are in a situation where either they or law enforcement or families see them as a threat to themselves or other people. It's really a crisis situation. If patients have the ability to make an appointment somewhere and, they're relatively stable, if they've been somewhat depressed, but, it's just, we are for people in crisis. And when we have patients who come in, because we see anybody who walks in that door, when we have patients who come in and they're stable, they're not always comfortable because you're amongst a group of people who are in crisis. And so, we do the best we can to keep the milieu quiet, and we keep the milieu where everybody feels as comfortable as possible. But it's for people in crisis. I know Mike Lappen has tried to emphasize that in the past, but that's something I think we really, as a community, need to stress to people. That's kind of the short of it. But what I really want to tell people is what we're trying to do right now. We've been open 3 months, right? We want to get better every day. That's my commitment to the task force and the community. We don't have everything figured out, and we're not pretending we do. Some of the things that we really are working on right now, one is to continuously improve the legal documentation and document transmission. That's something, if we don't get that right every time, then there could be somebody who's potentially a threat to themselves or the community who sees that Chapter 51 dropped on a technicality. We do not want that to happen. We want to take care of that right every single time. We want to develop the most robust discharge planning system, working with BHS Crisis Services, working with the Milwaukee Healthcare Partnership. We're not there yet, but we will get there. It may take us a little while, but I see us as a catalyst for getting people, I think Mike and others have talked about, there's no wrong door. We will get you to where you have to be, even if you come in and maybe this wasn't the right place for you originally. And then I guess those are some of the biggest things. Just kind of improving that MHEC inpatient service and stabilization piece. We're really for stabilization on the inpatient side, and we've been slow to see patients on that inpatient side. We need to get up to 30 inpatients before we can be surveyed and, have DHS and CMS bless us and make sure we're a fully licensed facility. So I need to get that done as well. We've been a little bit careful about that as we try to get our emergency services off the ground, because let's face it, we're replacing PCS, and that emergency service was job number one. But, 3 months in, I'm just going to say to all of you on the task force who were part of designing this new system of care, I think you got it right. I really do. You know, is every piece of it working perfectly yet? No. But I'm really proud of what's going on at MHEC. We are pretty much fully staffed when it comes to nurses and techs. I mentioned we were slow on the uptake with social workers. We're there now. The other thing was we had an interim chief medical officer, and that was Dr. Krishna Mailavarapu. But Krishna was the medical director or chief medical officer for all of Advocate Aurora's Illinois and Wisconsin behavioral health services. He gave us every moment he could, which is why we're open and why we're where we're at. But as of Monday, this past Monday, yesterday, we have a new CMO, Dr. Julie Owen. And I don't know if anybody knows her in the community, but Julie is a psychiatrist. She used to work at PCS quite a bit. She's currently working as the medical director for Freighters, Emergency Services Psychiatry. So this is what she does. And she's going to continue to do that, but she'll be 0.6 with us, which is 24 hours a week. If I have 24 hours of her time, we are going to do amazing things together. So 3 months into it, I feel really good about where we're at, but my commitment to you guys is we're going to keep getting better. And if you guys have ways that you want us, you have suggestions for us to get better, anybody can reach out to me and I will respond to you. I'm sorry. I probably took a lot of time, but thanks for giving it to me.
Kevin, thank you for taking the time to walk through all the questions we provided and provide the data we requested. That's really appreciated. I think that we do have time for just one more question before we move on to Mike Lappen. And there is a question in the chat from someone who works with the VA. Would you take a minute to address that as well before we wrap up? And thanks again for the time that you provided us with today. We appreciate it.
Sure. I can't answer that definitively right now, but you know, Barbara, I will get the answer to that and I will get it back to you. Okay. That's a great question.
Yeah, thank you so much. And thank you, Donna, for the question. We're really glad to have participation from VA here and from Zablocki. You play such an important role. So
thank you. Thank you so much for letting me be on. And if I could be a contact, we can have this discussion offline too. So just wanted to put that question out there. Thank you.
Sure, Donna. And I just want to say, Donna, the interpreter, I couldn't help but see her, interpreting, and she is so much more compassionate looking than I am. So I appreciate that too. And I know I'm done, but I just want to say, and I'm sincere in this, we have made a ton of changes to this place based on feedback that we've gotten from the community, from people who came through when the task force came through and the mental health board and the advisory committee. Keep giving us, if you hear things in the community or you hear things you think we should do to improve, please pass them on. I need that.
Evan, has anything happened with adding any peer supports in? Because peer support is monumental.
I don't disagree. We don't have it in the facility, but I know our patients are being linked to that after they leave. There's just been some question about the viability in that time of crisis. So I think more to come on that, Mary.
Okay.
And I'll just jump in, Mary. Our biggest challenge has been recruitment for Team Connect. We just haven't been able to recruit the clinicians and the peers that we need. We have the positions. We really want to do it. And I'll address that as I talk about the rest of BHS, but it's just been really challenging to recruit the team members to be part of that resource for us.
Okay. Come back, Kevin.
I'll come back and I'd love to bring Dr. Owen at some point. You know, from the clinician side, I think it'd be great to hear from her.
That would be wonderful. We'd
All right.
like to, how are we doing on time, Barbara?
We're right on target. Kevin covered the questions, the timeline we had, so ready to transition. Thank you very much, Kevin.
Thank you, guys. Bye.
Thank you, Kevin. Okay, next I'd like to introduce Mike Lappen, the Administrator for Behavioral Health Services.
Hey, everybody. Thanks for the opportunity to provide an update. Thanks, Kevin. Kevin's right. We've been working together seemingly daily, at least multiple times a week between his teams and mine to try to make this really gigantic transition in our community happen and be successful. I'm going to start out with the sort of the challenges just that we face. Behavioral Health Services has more than 100 openings right now, 31 just in crisis mobile alone.
I gotta get down.
That is just the overriding challenge, both at the services we provide at BHS and the services delivered really throughout the continuum of care. I don't think there's any agency out there that is fully staffed and that isn't struggling. I know a lot of providers are out in the audience today, and it's just, there's never been anything like this in my career. It is substantially impacting inpatient capacity, which puts a strain on the whole system. We intended to have Granite Hills Hospital up to 48 beds. By today, they just have not been able to achieve that. They're operating about 24 adult beds and 10 youth beds. That is something we're working on. Very specifically, they have deployed 5 resources, 5 staff people from their national organization to the local hospital to support it. They have a new physician recruited and a new team in place that they plan to open a 3rd unit in early January. I believe the target date is January 7th. So there is some light at the end of the tunnel, but that lack of inpatient capacity really throughout the system. And it's not just Granite Hills. In a recent report, every inpatient psychiatric hospital in Milwaukee was operating at far less than its licensed capacity, all due to staffing. The majority of the staffing challenges are on nursing, but there's also a shortage of psychiatry and techs in our community. So that's been the biggest challenge in general. The most concerning and dire challenge really is on the inpatient side, because while most people, and I think if you look at Kevin's data, something like 12% of people that come to the mental health emergency center end up being admitted. When those people need to be admitted, they need an inpatient stay. That's just the way it is. And so we need to have that piece to the puzzle. Again, we always try to focus upstream. We try to focus on alternatives to inpatient, but you need adequate beds locally, and we haven't been able to maintain those as planned. You know, when we first started these conversations in 2018, nobody considered the fact that there would be a global pandemic and that employment would just drop off. And, you know, the pattern has been, there's a new phenomenon in healthcare. People are literally ghosting employers on their first day. There's been a number of instances when on somebody's first day, after they've been trained, after they've been put on a schedule where they just no show for their first day. That's happened a couple of times, even at BHS with some of our new staff. It's a phenomenon we have to get over. We have deployed a team through Kane Communications to recruitment in all spheres, but we're really focusing our crisis services. So crisis mobile, our community crisis clinics, Team Connect, all that sort of stuff. That is where our campaign is focused. You will all start to see there's going to be some features on Lake Effect on NPR. We have some recruitment efforts lined up. Those will kick in just past the holidays. The holidays are not the time to recruit new staff. So we're really targeting early in the new year for a pretty massive recruitment campaign. For those of you who've been around for a while, we did a similar campaign around nursing about 5 years ago with great success, where we were really able to fill some tough positions that were really hard to fill. So we're optimistic. Additionally, there's a program at BHS around internships and developing new internship opportunities, not just in BHS, but across divisions. It also includes some of our community partner agencies who are doing similar things around recruitment and utilizing internships to develop local talent. We will just continue to expand that population of people that we provide internship opportunities for. We also were awarded a qualified treatment trainee grant to be able to pay people who are interns, and have developed a number of paid internships. Our hope is we develop great folks, they graduate and they come work for us, and they're already aligned with our mission and trained and ready to go. And that the word gets out, and these internships become the desired place for people to complete their experience at grad school and maybe their postdoc or their post-graduation hours, and that we become a place that is known as the place to go to get a quality experience. I don't think you can get a better experience than working in our system. I think working in our crisis service is an amazing opportunity to learn what it's like to be an effective crisis clinician. We have amazing supervisors, lots of experience, lots of mentors in our system. And so that's the call to action I would throw out to all of you is, spread the word, whether it's a student in your life or it's someone who's entering the field. Have them look to us and consider us. All those positions are posted on the county website. If people have specific questions, steer them to me. I've had a couple of successful opportunities where I'm randomly talking about our services in a venue like a school or in the community, and then people hear about it and we make the connection and they've actually become interns and employees. And so that one-to-one word of mouth is a really great thing and really powerful. So I appreciate it. You guys are all connected. So I suppose I'm also competing with many of you, but the idea around developing new talent really applies. Whether someone comes to work for us after their internship or they go to work at one of the partner agencies that work along with us, that's a win for our community, and that's really a goal. We've had some notable graduates end up in key positions around the community, and we just hope to continue that going forward. We have opened our access clinics. So we're back to in-person appointments at the new Milwaukee Mental Health Clinic, which is the clinic on 19th and North that replaced our wellness clinic that was formerly operated by Wraparound. So we started to see people in person for the first time in going on 3 years. We've also had our opening at Access Clinic North, which is a partnership with MHSI at the COGS Clinic on 82nd and Silver Spring. All of those programs are in different stages. As you may remember, 16th Street is a larger program. Outreach Community Health Center has a clinic that's been around for a while in partnership with us, but now we finally have the full complement of access clinics that we planned. The idea is that people can walk in there pretty much any day. The last walk-in appointment, I believe, is at 2:30, but they can see a prescriber, they can see a clinician, they can have a crisis assessment, and they can get connected to whatever services they might need to meet their needs. We're doing our best to make those services as low barrier as possible, and we continue to work together. In fact, I'm meeting later this week with Dr. Cole and the team at North to kind of discuss how we really get the word out and continue to expand. Again, the biggest challenge there has been staffing and making sure we have enough clinicians in place to complete the work. We've seen some positive movement in that regard. The county has increased their vacation allocation for new hires, and they've also provided us some shift differentials for second and third shift and weekends. So we've seen some movement in being able to hire because it was a real challenge to hire folks to work in those off shifts without any sort of shift differential, when most of the hospitals and other facilities that do nights and weekends pay better on those days and in the evenings. We continue to move forward with a number of initiatives around crisis housing. We just learned that a collaboration between the housing division and BHS to add 20 crisis, basically emergency crisis units on the north side of Milwaukee has made it through BOZA, and we will be working to operationalize that project. The developer is developing the project, which will be a mixed use facility, and there will be permanent supported housing, but in the same facility, we will operate 20 beds of crisis housing. The idea is to be able to provide safe housing for people in a crisis, and then wrap support services around them. ideally it's a short-term stay, but that it's an effective stay and it puts people on the path to long-term housing. We have a number of opioid settlement proposals. We're competing like everyone else in a program that is designed to be fair and to meet community needs. And so we've submitted a number of proposals to the ARPA committee, which is, I'm sorry, to the opioid task force committee or the opioid settlement committee, which looks a lot like our ARPA project process, in that we want to make sure that these initiatives meet the target needs, that they're equitable, that they make sure that the services get to the place they need it the most. Our projects include a proposal to expand the medication assisted treatment program, MAT, behind the walls in a facility formerly known as the House of Correction, our Community Reintegration Center, I believe they're called, CRC, not to be confused with CRC. We have a couple of other projects. We've also gone forward with some harm reduction models. You may have seen, we have purchased 25 vending machines to distribute harm reduction supplies. Our vending machines will include fentanyl test strips, Narcan kits, Datura bags, and gun locks. And there is a process in place where community organizations are going to be able to basically sign up to be considered as a location. We want to have the first 7 vending machines will go to the top 7 zip codes in Milwaukee as far as overdose documented overdoses that have occurred. And we need community partners to have those vending machines in their locations. They have to be at room temperature because you have to keep the Narcan from freezing. So they have to be indoors, but these will be low barrier access to harm reduction supplies. It's free. You'll just have to walk up and push a button and you'll get those supplies. We'll be working to find those agency partners to make sure that somebody at all those locations is trained on all of those harm reduction supplies. And then we have an agreement in place working with Vivint to make sure that those machines stay fully stocked. We will base the future allocations of machines on the success of those programs, and we'll make sure, or those machines, we'll make sure we add machines to the neighborhoods that are using them the most. Additionally, we are continuing to focus on our Better Ways to Cope campaign, focusing on prevention and awareness to try to get the word out upstream, and for young people to implore them to avoid getting involved with opioids in the first place. We also continue to work on expanding our community-based system of care around residential, sober housing, outpatient services, community services, to continue to expand the continuum of care with really the primary goal of keeping our citizens alive. We're really trying to focus on prevention of death due to overdose. We want to work with people. We want to help them as much as we can. If they're not ready to recover, we want to provide them with harm reduction supplies so that when they make that leap and they're ready to enter that recovery phase, they have an alliance with us or one of our providers. They know where to go. They know what services are available to them. So these are a number of things that are going on. I want to leave a few minutes just to answer any questions that people have or any concerns. Always happy to do that. These are just sort of the highlights for those of you who were not able to attend the most recent mental health board meeting where we talked about some of these developments and new initiatives in the community. So I'm at your service for questions. I'll peek at the chat here, and of course anyone should just let me know what you have here. Oh, Denise, thank you. Yeah, it's a good idea. Promote on TV with captions. You know, the big challenge for us is that TV time is so expensive. So we always have to pick and choose how we use TV because the airtime is just so expensive. And unfortunately, we don't have an unlimited amount of money for those sorts of things. Barbara, can access clinics be promoted with external signage on buses? They're very visible. That's a great suggestion. We've used bus advertising. I know in my neighborhood, when I go for walks, there is a billboard on the corner of 55th and Valete. Every day they do the Kneel for 9 there. It's a busy intersection, and there is a BHS billboard advertising crisis services and connections to our crisis line and access points there. But we also have done the bus ads Keep an eye out for them. We've done them in a couple languages and a couple different styles. There is a substantial effort there. Again, you know, we have to pick and choose. So ideas about which particular neighborhoods are key, which particular bus stations or billboard opportunities make the most sense. We really want to make sure we're really blanketing the community, especially those parts of the community that are traditionally underserved with our services. Yes, the acronym Behavioral Health Division has been changed to Behavioral Health Services. I'm working on it. It's hard for me to get used to. So my New Year's resolution for 2023 will be to never say BHD, only to say BHS, but it's tricky. Yeah, it's Denise makes the comment in the chat about how it's a challenge with college being so expensive. I think that's why paid internships are so meaningful in this space. I know many of you who are my age, you know, when I got my license, I literally had to work for free until I got my hours, or I work in a really a much lower job than I was trained for because the reimbursement was poor. By offering some paid opportunities, we feel like that makes it easier for people. We can pay people a sustaining wage with their bachelor's degree in our crisis service as they earn their master's hours. And I think that's something that distinguishes us from a lot of employers. Barbara, to your question, the reason the name was changed is the idea was to eliminate the divisions in the Department of Health and Human Services. That division, just by definition, implies silos or barriers. And the idea is we want it to be known by our services as opposed to the division. It also, the class standards basically call out for words to be translatable. The translation of division doesn't exactly sound welcoming, whereas services is a little more universal. So the idea was to make all the services sound more universal and more accessible to people who may understand services versus divisions. Montreal has given me his number here, which I'll write down. Are there other questions that I'm missing? Things maybe not in the chat?
Mike, if you scroll all the way down, there's a question asking about how this will impact youth. I work with youth 11 to 25 years old.
Oh, great.
Good.
Yeah, so a lot of our efforts around the prevention space have been focused on youth. We continue to expand our youth CCS. Our first episode program is up to 9 teams. I was just at the WICSA Fall Conference, the Wisconsin County Human Services Association Fall Conference. There's a team in northern Wisconsin that serves 32 individuals in 9 counties. So the fact that we have 9 teams in Milwaukee County is a sort of a testament to how far along we are in that project. You know, but we're there to provide services for youth. We have a youth clinic. We have a long-standing and successful program in wraparound. There's a REACH program, which is a little less intensive version of wraparound. We also have UCCS, which I think is probably the single most amazing opportunity in our community, that there's essentially unlimited capacity in our CCS program in general. And for transitional age youth, as they get closer to being adults, you don't have to transition from literally one provider to another. CCS is a service that can really follow people based on their needs as they age. And I think that's really important. One of the challenges has always been transitional age services. We used to operate a program called Oh Yeah, and I always space on what the Oh Yeah acronym stood for, but the idea was for transitional age youth. That program has folded into CCS because the CCS program was so much more flexible for youth and for that transitional age target group. So, you know, there's a substantial number of services for youth. Again, the biggest challenge has been staffing concerns and limitations. The care coordinator network has struggled to maintain staff. Our youth crisis mobile has struggled to maintain staff. We always have our services in place. We really haven't missed a beat, but it's harder. And it's harder to be there as fast as we want to be. It's harder to get people in as quickly as we want to be. So we just continue to do everything we can to meet the community demands as we grow and try to build back those teams. It really goes back to the pandemic where things got set back and many things have recovered. It's been a bigger challenge for some of the longer term programs to get back to the staffing levels they enjoyed before the pandemic. Any other questions for me? Montreal, I did write down your number and I'll give you a call.
Denise has a question.
I do have a question. The prevention to youth, a barrier to youth. I do presentations in the deaf and hard of hearing and deaf-blind community for youth. And I'm at the point where I need some resources. And I need to gather those resources to provide to them to teach prevention. I don't have enough resources. And if any one of you on the here today can help me, that would be great, especially if those resources can be configured to work for deaf, blind, and hard of hearing folks, right? Does any of you have the similar struggles to provide resources to overcome barriers, and especially with regard to prevention for those youth?
Well, I'll make the connection, Denise, with our prevention coordinator, Jeremy Triblett. We've made substantial investments in prevention across all programs, and there are materials that I believe would be accessible for people who are deaf or hard of hearing. Prevention is key. It really is the key, and awareness of what is available to folks. So Jeremy
exactly right. It's key.
Yeah, it's a huge deal. So Jeremy is there, and he's been doing an amazing job. We've added some other resources around prevention, and we continue to make those investments. The 2023 budget is very strongly focused on prevention, aligned with the county executive's vision. I mean, the idea here is to make Milwaukee a healthier community. The only way we're going to do that is if we can prevent folks from falling into some of the traps around substance abuse, and if we can only help people sooner before they have that life-impacting experience related to their mental health or substance use disorder. That we really have to help people sooner, because once someone has an arrest or an emergency detention or an eviction or that sort of thing, or they lose their job or they alienate their family, it's so much harder for them to get back on that recovery journey. And so those investments, we believe, are really key to a healthier community, and that's why we focus so strongly on prevention.
Okay.
You have my email, right, Mike? You can
I
send me
do.
that.
Absolutely. I'll make the connection.
Thank you so very much.
This is Barbara. I just wanted to say, you know, how much we hope that the mobile crisis team will be at full capacity again. I know you do too. You know,
Absolutely.
it's something that we always advocate for, the funding in the county budget and in the state budget. And it's just such an important resource, and concerned that, you know, where do we go with this?
Yeah, and we do too. You know, for the first time, I can actually say funding isn't the problem. It's basically recruitment. Two quick things that teasers. We're working really hard to combine all of our crisis mobile teams under really one banner, and we hope to relaunch them in the new year as soon as we have the staffing. Not because of anything other than we want to make it as easy to communicate, to get a hold of us, and as easy to access those crisis services as possible. So the teams are working through, like, is it a name change? Is it a single number? But we have combined the crisis mobile services all in their totality under one leadership under Lauren Hubbard. And so we still have a clinical consultation team doing very special work. We still have a geriatric specialist who does very special work. We have staff who are children's experts. We have staff for adults. But the idea is we thought it might be better if people could just call one number and access those services. So often we go out into a community call and there's an adult and a child. And so we want to make sure that we're serving families and be more proactive. The other exciting development is that the state budget proposals, I am told, will likely include the fully funding of the CSP programs. I've done a bunch of lobbying on this topic. That's about a $7 million impact to our budget, which we would be able to.
Mike, I'm sorry, this is the interpreter. Fully funding what?
I'm sorry, CSP programs, or community support programs.
Thank you.
And so if we were to achieve full funding, because today the county has to pay a match, if we achieve full funding, we could pass along that expanded funding to our provider agencies. we know the rates aren't great. We know people need to get better rates to hire better staff and to have all those things that make it. Our goal is to achieve that funding and then move further along the lines of ACT Fidelity, so assertive community treatment at Fidelity, and really get our programs, enable them to move along and hire those staff and make those program expansions that will better serve those people in our community that benefit from those teams. They have a $6 billion surplus. They can certainly afford it. It's about a $25 million investment statewide. We're about 30% of the statewide CSP population. So that's a big deal. And there's also work in looking into crisis reimbursement and improving crisis reimbursement. And so those are two places where, you know, we could pass along those reimbursement enhancements to hire more staff and to make our jobs more enticing, and also to support this, you know, great network of providers, again, many of whom are here in the community, in the task force community. We know the rates aren't great. The Medicaid rates just aren't what they need to be. But every opportunity we have to enhance those rates, we're going to take. And so if you have an opportunity to support these initiatives in the budget, please do so. WCA and the Wisconsin County Human Services Association has published papers supporting these endeavors. And I think we have buy-in. It's not just a benefit to Milwaukee. This would benefit the whole state. In fact, I think the rural communities actually are struggling. We have local infrastructure to make this happen. But if you're a smaller county, it's harder to run a program like this. So that enhancement would benefit the whole state. Unfortunately, we always have to say that, because if things just benefit Milwaukee, they have a way of dying in the legislature. These are initiatives that, you know, I'm super passionate about. And again, if you'll have the opportunity, please do your best to help me lobby for these improvements. Again, relatively small investment from a statewide perspective, but would have a huge impact locally. So.
Thank you, Mike.
Happy to come anytime. Happy to come anytime.
Okay.
Happy holidays, everyone.
Thank you. Thank you. Happy holidays. I'd like to move on with our next speaker, and I'd like to thank Chris Hagee, one of our new steering committee members, for recommendation for this speaker. It's on veterans and peer support, and it's Matt Lemke. And Matt will share his experience as a veteran with a spinal cord injury and how he navigates peer support. So welcome, Matt.
Can you hear me?
Yes, we can.
All right. Good afternoon, everybody.
Good afternoon, Matt.
Welcome.
Have Chris bring up the slides so we can go through everything. All right. I'm a veteran. Mental health runs in the family, and I've had mental health struggles in the past, particularly with suicide, substance abuse of other than cannabis. I always like to state that, because cannabis is my friend, everything else is my enemy. So, I'm the president of a nonprofit that we try to connect people with disabilities with game systems for Xboxes, PlayStations, or Nintendos. Because for me, that helped me not want to be suicidal, and it gave me something to do every day, because I'm a quadriplegic, C4-5 quadriplegic spinal cord injury from a military injury that I sustained when I was 21. I'm 44 now, so it's been 23 years. I'm, like I said, I'm a big gamer. I'm a veteran, and I'm an advocate for for cannabis. I want to get cannabis legalized in all the U.S. and particularly in Wisconsin. So that's my opening So in my experience, transportation, getting around town, getting to places to meet with people, with the VA system, I can get to all the appointments with their my transportation department. They pick me up, but anywhere else I want to go, I've got to try to find somebody to take me in my vehicle or pick me up in a wheelchair accessible vehicle. And then my mental health issues that I had to deal with, being lonely and isolated. And yeah, there was attempts of suicide. I had the kit. I was all ready to be on board with that because I didn't have any hope or no answers. I didn't have anybody to talk to really. But with the mental health group that I got involved with at the VA, they put me on some medicine. They also allowed me to do some counseling, and with their chaplain department, I was able to get on board with spiritual stuff as well. So a lot of things going on. What's the next page? Counseling. All right. These are the veterans organizations, the PVA and the DVA help a lot with veterans that are in need of supports, all different supports. And then the Stack Up is a nonprofit. So I didn't have a game system for probably 15 years, 10 to 12 years, 15 years. I didn't know I could play. I was introduced to Chris when he worked at Independent First, and he's like, "Yeah, you can play, bro. Just come on, let's give it a try." So being at the Milwaukee VA introduced me to Chris, and that's what got me on board with being able to play the Xbox, which gives me something to do every day. I'm allowed to talk with other people anywhere in the world. I've got friends from different countries for different video games that I play, depending on what kind of mood I'm in that day. I've got stuff to race. I got stuff to kill other people. I've got stuff to grow different environments and stuff. So it's a big genre. Depending on what mood you're in, you got different scenarios you can play. So it keeps me busy and something to do. The different video games have different scenarios and rules that apply to them. So that's always the awareness level when you get involved in these stories. It's something. It's kind of hard to explain. It's something that keeps you going. It gives you something to do every day, a mission, something to accomplish, goals. It keeps you moving forward, keeps the mind busy. As long as you keep your mind busy, then everything else just fades away. It makes life a lot easier. The esports is really important to me because I think the more people that are allowed to be involved in the esports, then it'll help us to have something bigger than ourselves to worry about and work on and do and compete with other people from, like I said, all the way around the world, to the same room, to your family across the country. It's a platform that breaks down barriers and makes it accessible to everyone. So that's important. So what needs to happen is we got to get our caregivers involved with setting up the systems. If I can't connect to the internet, or if I can't get my controller adjusted the right way, or if something breaks, that they got to do the repair job for it. So we got to be able to educate the caregivers that are involved with people like myself. The system, that's the system supports as well. The financial accessibility, we need more money, just like everybody else does in these programs. I was given from Stack Up like over 45 games for free. Like I had no Xbox. I was able to raise the money for the Xbox, but I went from zero to hero with the games that Stack Up was able to provide to me. And that was huge. So opening the nonprofit, that was really important for me with the inclusion. I want to pay it forward. I want other people that were losing hope like I was to be able to have access to video game systems and video games like I was able to, because for me, that was a big part of my life before I was injured, was playing video games when I was in the military. That's what you do on your downtime, is play Call of Duty. Back in the day with me, it was 007, James Bond. I mean, it's just something you do. It's part of who I was, the gamers out there. And everybody in the world has a game that they play online or on a computer. And almost everybody does, even if it's just solitaire or if it's Call of Duty, like I said. There's people that play electronic games everywhere. So to me, that's important. The industry needs to come up and incorporate these features. Right now, I'm playing on Xbox with an adaptive controller, but I'm not allowed to talk with the microphone currently. We're working on getting that, but it should be something that's accessible to anybody in my position, that they'd be able to speak verbally with them. I have to do it all text to speech or text, which is fine because I'm still talking to the people. But it would be nice to be able to communicate like the other people do with their voice straight up, because it's a lot quicker and it's a little more honest, I think, in my opinion. And then with the assistive technology for esports, right now they're not always allowing people like myself to participate because of the adaptive equipment that I have to use. They say it gives a cheater's edge, but they need to make a default loop or some kind of device that makes it so that it is equal to playing with other people, because I think I have the same right as everybody else does to be involved in these tournaments that they quite frequently hold everywhere. All right, so can you click on this for me? Get rid of this one too. Can we move it? Let's get it. All right, so I can play with people anywhere in the world. We need more social capital for that. The caregiver education involvement, like I said, was speaking earlier, we need to get the caregivers more involved and to be able to learn how to fix my systems and support open source assistive technology. That's for so there's no codes, or everybody in the world can have access to the programs that do all the work that we need them to do, and instead of blocking certain groups out or certain people out. And then we need to advocate for the inclusion of policies in the esports. to allow people like myself to play, like I was saying. What else would you like to know? That's what I've got. Any questions from anybody?
Matt, this is Barbara Beckert. Thank you so much for the update. I thought that your recommendations were really interesting and they seem really solid, and that can be such a therapeutic practice. And I just wondered if there'd been any thoughts about reaching out to some of the organizations that provide long-term care to promote this as a tool for their members, if that's something that might be potential for increasing awareness.
No, absolutely. I want to get it in wherever we can. I mean, it would be great that this would be a most beneficial program to be able to spread it out even in nursing homes. Old folks got stuff to do too. And with the whatchamacallit, the new Oculus, the 3D VR, the VR headsets. You can go shopping online and it's like you're actually at the mall and shit. It's knockout material that is accessible. If you got Wi-Fi, you can do this stuff anywhere. Anybody can do it anywhere in the world. So yes, that would be something that would help.
Very cool. Well, I think that would be a great group to do some outreach to. So.
Hey,
you
Matthew,
wanna-
Montreal.
Matt, have you thought about teaming up? This is Mary Neubauer, one of the co-chairs. Have you thought of teaming up with somebody out there? There's a company they're in Minnesota, Denver. It's called PC for People, and they refurbish computers and they offer Wi-Fi, and they've been around for a significant number of years, and they offer the discounts for the affordable care programs, and they may be
Excellent information. I'll scoop that up. I'll have to get that information from you.
okay. They may be interested in, because they do the refurbishing of all their computers, and they do warranty work and stuff, and they may be willing or interested in starting a program like this.
Absolutely, yes, ma'am. I'll take it.
All right, I'll get in touch with you.
Thank you.
You're welcome. I cut somebody off. Montreal, I think I cut you off.
Oh, no worries, no worries. Matthew, this is Montreal Kane. I'm a part of the steering committee here for the Mental Health Task Force. I absolutely loved your presentation. Thank you for your service. I put a link in the chat for a company called Telka. I was the accessibility champion for 33 stores with Apple Incorporated, and I was able to get some free technology from Telka and install Atari-like controllers to wheelchairs that allow you to interface with gaming systems through Bluetooth, as well as like iPads and Kindles and things like that. So definitely reach out to Telka. I think it would be a great connection for your organization. Keep up the great work, man.
Thank you.
Thank you for your service, Matthew.
Hey, it was my honor and privilege. My honor and privilege.
Any other questions or comments or input for Matthew?
This is Barbara again. I just wanted to indicate that it would be really interesting to get an update, down the road to see how things are moving forward with the recommendations, and is there any way that, people on the task force might be able to offer ideas or anything. Let us know.
Yep. I got your email.
Well, this was really such a positive presentation, really gave us all a lift. So thank you for the work you're doing, Matt.
Here to help. That's all I can say. Here to help.
Thank you, Matt. And thank you, Chris, for connecting us to Matt. Have a great afternoon, Matt.
Yep, you too.
Okay. Bye-bye.
What?
Next, on the agenda, I'd like to introduce, we have a presentation on mental wellness during the holiday season. And it's Dr. Leah Knox. And I'd like to thank Montreal Kane for our connection here. And Dr. Knox is the mental wellness expert and founder and CEO of Knox Behavioral Health Solutions and co-founder of the nonprofit Black Space So Incorporated. Welcome, Dr. Knox.
Thank you so much for having me. Thank you everyone for your presentations today. Thank you, Montreal, for inviting me and all the communications I've had with Ms. Barbara. I appreciate you. And so today we're going to be talking about mental wellness during the holiday season. Matt, your presentation was phenomenal and it ties right in with the holiday season. There's so many people that are celebrating all of the lights, the glitz, the glam, the holiday songs, and there's so many people that are very joyous. However, there are many people who are isolated, as Matthew described. There are people who are dealing with the loss of loved ones or feeling very lonely. Many people do not enjoy the holidays and they have a very difficult time during the holiday season. So I wanted to talk about some of those things, as well as some strategies and techniques to cope with maybe that loneliness and sadness during this time. So today has been a time of technology blips and bloops. Not sure if that can be interpreted. So we're going to try to share my screen. First thing I want to do is share some, let's see if we can do this. 1 second. All right, I'm sharing the screen. Disabled it. Go on now, give me 1 second. All right. Can you see anything?
No.
All right, it is not going through for me. Let's try it one more time. Going to the screen share, but it's not letting me share for some reason. Let's try again. Come on, screen share, work with me. All right,
Oh,
here we go, yay.
um,
I'm gonna go to my actual, here we go. Come on.
we've got the launch meeting.
Yeah, I'm gonna go to.
Oh, okay, got it. Okay, okay. I see what
This
you
has
did.
been doing wonderful things all day. Here we are. Thank you for your patience, everybody. All right, can everybody see?
We're good.
Thank you so much. So we're going to be talking about mental wellness during the holidays and how that may affect different people. So let's go for it. I want to start with some statistics. So not sure if you know this, but 3 out of 5 people feel their mental health is negatively impacted by the holidays, which most people don't even realize. it's very difficult for that to happen with a lot of people. When you're in the spirit, everyone around you is doing so well, you're not doing that well. 56% of people in the United States wish the holidays were just completely canceled due to stress. 64% of people feel an increase in mental health stressors during the holidays. Did you know that 60% report an increase in anxiety and 52% feel an increase in depression? 70% feel more financial stress and 66% reported feeling lonely. So I know people don't really ask this question because most people feel that 100% of people feel vainglorious during the holiday season. So this is very much so important to know. There are many sources of holiday stress as well. The top source of holiday stress is shopping for gifts. So please raise your hand or put in the chat if that is you. Next, managing children's excitement. So those of you with children, or those of you who have nieces and nephews, godchildren, or even people in your lives, those who have children that may be going to school or that know children, managing that excitement. Those of you who may know children who have an Amazon list of shopping, or those of you who may be around my age, and I don't want to age myself, the JCPenney catalog, the Sears catalog, all of those wonderful things that are now online. It's difficult to manage that, especially when you may not have the money to pay for those things. Navigating difficult family dynamics. There are some people that get more anxious during the holiday season because, oh man, now I got to have dinner with the family. Or here we go, Uncle Bob's gonna be there this time, or we're gonna have some type of conversation that makes me feel extremely uncomfortable. Or now I'm gonna have to face some things that I don't wanna face, and this goes on every year with my family. Another holiday stressor, managing mental health and addiction issues. It's difficult because you have people that expect you to be at certain places. There are more alcohol served. There are more parties going on where drugs that are there that you may not want to take or may have been addicted to at one time. Recovery is challenged more during the holiday season than any time of the year. Once again, depression and anxiety symptoms tend to increase as well. Also, family conflict and holiday expectations. There may be some people that expect you to be there or expect you to give a gift. Family conflict increases because anxiety and depression increases. Also, there's so many people in one place at one time, which in turn increases conflict. Finally, navigating COVID logistics. Most folks today may think that COVID is gone now, when in fact, no, there's some people that are still following precautions. So they may choose not to come to some situations. They may choose to wear masks. They may choose many things to follow logistics and may be judged for such behavior. Next, we'll have many things that go on with the holiday season, but sometimes holiday blues can also be mistaken for different things, but SAD, seasonal affective disorder, can also come about during the holiday season. SAD is seasonal affective disorder, and it's experienced by 1 out of 3 people, which is 10 million people in the world, mainly in the United States, from October to April. So sometimes you may feel that someone or even yourself is experiencing holiday stressors or what people have termed holiday blues, when in fact, you may be experiencing seasonal affective disorder, which in turn is called SAD. Most of the major holidays are celebrated between October, and January. Of course, we have Valentine's Day in February. Sometimes Easter falls in April as well. But sad is often mistaken once again for holiday blues. When this happens, the days become shorter. We have darkness or fog or just kind of dreary times. If you look out your window now, there we go. Symptoms tend to resolve in spring and early summer. In others, symptoms continue in spring and early summer, then resolve in early fall due to hormonal changes. So I want to describe some of those symptoms for you. Some of the symptoms include lack of patience and irritability, feeling unproductive or unmotivated, feeling sad, depressed, weight gain, weight loss, reduced sex drive, craving sugar, carbohydrates, feeling of hopelessness, social withdrawal, sleep disturbances, feeling very tired and lethargic, feeling a sense of doom. There are others that are not on here. Some of those include legs and arms feeling very heavy, not wanting to get out of bed, tearfulness, excessive tearfulness, thoughts of suicide, attempts of suicide, not really wanting to go out and do things with friends and family. So these are things that you need to look out for, and they could possibly be symptoms of seasonal affective disorder. So how can we combat seasonal affective disorder? One way is light therapy from a 10,000 lux light box or lamp for 30 minutes daily. You can get these from Amazon for as low as $10. You can put them in different places in your room, in your office, anywhere that you would like. Daily walks or other exercise in the sunshine. Sometimes people say, well, there is no sunshine throughout the day, but if you're able to go outside mid-morning between 11 and 2, even though it's cloudy, there are some type of sun rays coming through those clouds. Sitting by a window would do that as well. Consistent sleep, making sure that you go to bed at the same time, waking up at the same time. A healthy diet with plenty of fruits and vegetables, protein, lots of water. Consider interacting in a support group and also therapy. It can be individual therapy, group therapy, a support group, pastoral therapy, a group of friends, a way to get out and talk about your feelings. Talking to your primary care provider about an antidepressant is also a good idea if you feel that your symptoms are becoming severe or persistent and they're not going away or decreasing even with some of these techniques. So here's some holiday tips, some things that you can do if you're experiencing the holiday blues and or if seasonal affective disorder has become a part of what's going on. It's hard to decipher which is which. So let's take advantage of all of these tips. First, make space for messy feelings like grief. A lot of times we want to say, let me just put this to the side because I don't have time for this during this holiday season. I have to shop. I have to cook. I have to do so many things. I have to take care of the kids. No, stop, sit, breathe in through your nose, out through your mouth. we can practice it now. Let's go, everybody. In through your nose, out through your mouth. Make space for feelings that may not feel so good. If you've lost a loved one, if you've lost a pet, if you've lost a job, if you've lost something valuable to you, if you do not have as much money as you would like, if you've lost a home or an apartment, if your health is not as well as it used to be, make time to allow those feelings and consider those. Learn to say no without feeling guilty. It's okay to say no. If someone's asking you to cook that dish, no. And you can say it with a smile. Let's practice. No,
No.
but thanks for asking. Look at that smile.
No,
No, but thanks for asking. You didn't apologize. No, I'm sorry. What are you apologizing for? You didn't do anything wrong. There's no need for you to feel guilty. Hey, can you pick me up and take me to the store and then to grandma's house and then to Walmart? And then after that, can you drop me off? No. And I know it's hard to have that pause afterwards, but that's no pause. That's just simply saying no. Raise your hand if you felt uncomfortable even thinking about doing that. Practice in a mirror. Learn to say no without feeling guilty. It's okay. Next, create your own holiday traditions. Some of us may have children, adult children, that are going with friends for the holidays in the midst of college, or we may have a different kind of relationship, perhaps divorce or breakup, or we may have smaller children now and we have gotten married, or perhaps we have kids now, we may not be married, or maybe we like to do something different and stay at home and watch Hallmark movies, or perhaps we want to game. Thank you, Matt. Or other things in our lives, and we want to create a new holiday tradition. It's okay. If mom, grandma, foster parent, adoptive cousin, whatever, wants us to do something different, it's okay to say, I won't be able to make it this year. I'm going to be doing something a little different, a little creative, but I'll let you know how it goes, and I'll even take a picture and send it to you. Smile. It's all right. Next, it's okay to be creative with those different kinds of traditions too. I have a friend, he and his family, instead of having these big, huge meals and different things like that, they go on a little journey. They'll either take the Greyhound bus, the train, drive. They'll go to a different location that's kind of nearby. They use Milwaukee as their tourist site now. And they'll just go stay there overnight, Christmas or New Year's. They plan a year in advance. They get all kinds of coupons and they just go on ahead and do it. That way, it's a new tradition for them. Next, keep your stress levels in check. It's okay to step back or delegate. I have a beautiful aunt who was diagnosed with cancer 2 years ago. And after chemo has taken a toll on her body, but she's the big mama of the family. So all of us go to her house. We have this fabulous meal that she would never let us partake in as far as preparation. So one year we just took over and we said it's going to be a potluck now. So each of us bring our most famous meals that we think we know how to cook, and we bring them over a few hours before the dinner is supposed to start. And now she doesn't have to do much. And there's 4 of us who come over and clean the house beforehand. And then there's 5 of us who break it down afterwards and clean up. And we just pretty much ignored what she had to say. And now all she has to do is sit back and let the family do the rest. Next, set realistic expectations for yourself and the holiday. If it is not realistic for you to go out and spend hundreds of dollars on a gift, don't. If it is not realistic for you to hit 4 households during New Year's Eve, Christmas, or any other day, don't. If it is not realistic for you to get up at 6 in the morning, just so you can get ready to do these other things, don't. You do not have to. It's okay to give yourself and others grace. Also, make a plan and try to stick to it. Organization is the key. You can write down your plan. I want to do 2 things a day and that's it. Today, I want to do absolutely nothing other than do me, and that's okay. Today, I'm the one that loves to bake cakes and I love to do cookies, so plan it out. If someone wants to interrupt your plan, let's go back to number 2, learn to say no with a smile. Also, keep your self-care routine or begin a new one. Going for a walk daily for 5 to 10 minutes. Go for it. Drinking more water. Do it. Breathing, self-care in, out, when you feel good or when you feel frustrated. Stretching, making sure that you give yourself affirmations. I am beautiful, I am healthy, I am worth it. These are all part of self-care routines. Taking a bath 3 times a week. Having essential oils when you feel as though your anger is getting a bit above what it should be. All of those things, keep your self-care routine in order. Do not skip out on it just because others want you to do things or you are having unrealistic expectations of yourself. And finally, give yourself permission to let it be a normal day. It can just be a normal day for you on a Tuesday, on a Saturday, on Christmas, Hanukkah, Kwanzaa, New Year's Eve, New Year's Day, Valentine's Day, Thanksgiving. It's okay. Just because the world says it's a holiday you need to celebrate, you can celebrate you. It's fine. So, 8 ways to survive the holidays and stay sober. We're just going to go through these quickly. Set realistic goals and limits. We've gone through that. 2, stick with the basics. You do not have to go overboard. 3, stay connected with those that support you, those that love you, those that bring you positive energy, smiles, and good times. 4, have an escape plan. Anywhere that you go that you do not feel uncomfortable or you feel pressured and you feel that you need to go and you end up there, have an escape plan. 5, create new ways to celebrate. 6, remember self-care. 7, meetings, meetings, meetings. This is how you survive the holidays and stay sober. Make sure you get to your recovery groups. Make sure you get to AA and NA. They have them online. They have them in person. Please remember the meetings. And 8, do something nice for someone. Volunteer. Give a gift. Go to a nonprofit and see if they need any help. Check your local paper and organizations. They're everywhere. Finally, restore, replenish, rejuvenate, refresh, and have a happy holiday. If you have any questions, I welcome them now, and I thank you all for listening. I'm gonna stop sharing, hopefully now.
Bravo, bravo.
Yay.
Thank you. Any questions at all or thoughts?
Ah,
I'm just gonna say no with a smile.
And I apologize for the technical difficulties. It's been happening all day with everything.
It looks like we have a hand up from Nicole.
Hi, Nicole.
Nicole, please unmute yourself and you can share your comment or question.
Can you hear me now?
Yes, I
Yes.
can.
Okay. Hi, Dr. Knox. Thank you for your presentation. I'm gonna drift off into another place, not having to do with the holidays, but I'm wondering if you can.
Uh-oh, Nicole, we'll wait for Nicole to come back. I think you froze, Nicole. Oh, there you are. Okay, there you are.
Can
I'm
you hear
back.
me?
Now we can.
Yeah.
Okay. Dr. Knox, thank you again. I am just
Sure.
wondering, not necessarily about the holiday presentation, but I'm wondering if you can share a little information about Black Space.
Absolutely. So Black Space, I am one of the co-founders along with two other gentlemen, Corey Fells and Darius Smith, and we offer free group therapeutic experiences for Black and Brown men, women, and LGBTQIA+ communities. Our main purpose is to offer those group therapeutic experiences in beautiful and safe spaces. So we do that. We have a partnership with the Milwaukee Art Museum presently for the next 3 years, and we offer them every quarter. Next Wednesday, we will be offering the men, Black and Brown men on Wednesday. I'm sorry, that's tomorrow. Men at 5 to 7. And so we want to destigmatize mental wellness within Black and Brown communities. We want to make it accessible. So always free. We want to make sure that people can get there. So it will always be on a bus route. If we need to make sure transportation is available, we will make sure that people get there. So if someone is not able to get there on bus, we will make sure they get there on Uber, transit, any way we can. We also know that if people don't have their basic needs met, it's hard to listen. So we always have food there and drink. And always by a licensed clinician. It's not therapy, but we want to make sure that whoever is facilitating the groups, which right now it's always me, is knowledgeable and able to answer certain questions. We also provide a list of Black and Brown therapists that are able to see people individually if in fact they've enjoyed the sessions and they feel like, oh, this therapist like thing isn't so bad after all. Perhaps I might want to go see a therapist, and then they can make sure that, you know, I'll call this person. Also, with mental wellness being destigmatized and the sessions are enjoyable to them, they tend to come back again and again. So that's Black Space Inc.
Thank you so much, Dr. Knox. I will have to get back to you because at Independence First, we serve people with disabilities, and we're finding more and more individuals coming in with mental health diagnoses. And I would love to have a list of counselors that look like the people that we're serving. I think that's an important piece to helping people feel comfortable with providers. And so I've been kind of struggling to put together a list of people in the area and would really like to hopefully have that list from you. So I appreciate your help.
That's no problem. And I try to refresh the list every quarter. So I look high and low. Montreal has been a huge help with that. MRI counseling is one, MindStar counseling, Imani counseling, Yahweh. So there's several, but I really search just high and low, and I try to do the same. And I do the same for different states as well from people who would need that. So I provide that service as best as I can too. So sure, I'll give you my information. I think it was on the first part of the slide. So if you didn't get that, we'll make sure to get that information to you.
Thank you so much. I really appreciate you.
You're welcome.
Also, if you guys go to the Black Space MKE website, there is a list for men and boys of color, young ladies. It breaks it down. So there is a list. I just grabbed them yesterday to add to our website.
Yes, and I'll keep on updating them in the LGBTQIA plus community, and also allied as well. And any place that we provide our groups is always accessible to those that may be in wheelchairs, crutches, walkers, what have you. So, absolutely. Any other questions or thoughts from anybody?
Dr. Knox, I'd like to personally thank you for this wonderful presentation. Was so meaningful for me and in so many different ways, and just sitting back and listening and just hearing you today was monumental, and you really touched my heart. Thank you.
Thank you, Mary. I really appreciate you. I've seen your name on a few emails, and just thank you for all you do in the community, and that just your words meant a lot. And I feel like coming and snuggling next to you in that comfy chair.
Thank you.
You're welcome.
I have my puppy next to me, but it'd be nice to have you here too.
Oh my gosh, I love animals so much. So thank you. I wish I could see. Is it a girl or a boy? Oh my goodness, big old baby. Perfect. Thank you, Mary. I think there was another question or thought, but I couldn't see. Oh, I couldn't see it. Am I sharing my screen again? I hope not. Let's see, can you put TH here? Sure. If you can, anybody can use the PowerPoint, that's no problem. Yeah. If anyone would like me to, you can either use the PowerPoint or I can go.
Thank you. Thank you very much. Thank you. Thank you.
You guys can open your microphones and speak also. You don't have to use the, you can have permission to use the chat if you'd like. I mean, the microphone. Any other comments or questions for Dr. Knox? Hey.
Yeah, I just want to, Dr. Knox, this is Barbara Beckert. I just wanted to add my appreciation. This was so helpful, and you had so many really concrete suggestions to help us navigate the holidays. So, wow, Montreal, thank you for connecting us and making this possible. This was really impactful. So I hope you'll come back again, and if any of the resources that you shared, we've got your PowerPoint up on our website, and hope that people can help to share it more broadly, if that's okay.
Oh, absolutely. I would love to. And anytime you want me to come back to discuss anything, I would love to. And if you would like me to present the PowerPoint again, with less technical difficulties.
Oh, you did
I would love
great.
to.
No worries about the technology. It was awesome. We'd probably, have more technical difficulties if we were all in the room together, right?
And before I end, we're going to practice this once again, because I know how we all are. I'm going to practice saying no. Okay. 1, 2, 3.
No.
No.
Oh,
With a smile in the mirror.
Mhm.
Thank you for having me.
Thank you very much. Happy holidays.
Happy holidays to you too.
All right, Barbara, I dropped my phone that has the rest of the agenda and I can't reach it.
Well,
But we just
thank
have
you, Mary. We just have
updates.
a few quick advocacy updates for
Right.
folks. So as everyone knows, 2022 was a big election year. So we have Governor Evers continuing on as our governor, but a lot of changes in the legislature. So we wanted to share with you just a few opportunities. First of all, Governor Evers is having a number of listening sessions on the budget. And I just put in a link in the chat to the post we have on my agency website, Disability Rights Wisconsin, about those options. We really encourage you to consider participating. You might not be able to make it to Kenosha for the one today, but there is a virtual listening session tomorrow. So you can do that from the comfort of your office or home. I see Denise has a hand up, so want to see if she has a question for us.
Yes, I do. I am curious, that governor's listening session, is that a last minute thing? I just heard about it yesterday. I was concerned because the deaf community needs about 2 weeks to get an interpreter to make those accessible. And I just heard about it yesterday. So I'm going to try to figure out, maybe use captions on the virtual session. That's maybe the best I can do. But was it a last minute occurrence, or what do you think?
So Denise, thank you very much for that question. So first of all, I'm willing to make a bet with you that there will be interpreters available, I bet, through the Office of Deaf and Hard of Hearing. If that's not the case, I would be very surprised.
Okay, we'll see. I'll bet you, Barbara.
Okay, we've got a bet, my friend. The notice that I received.
Am I going to say no with a smile? Maybe.
The notice, I'll email the governor's office if you want and ask Denise. I'm happy to do that, if you'd like me to do that.
That would be great. Okay,
And
thank
we'll do that right after our meeting. So there was not a lot of lead time. I received the notification Thursday afternoon from the governor's office, and I did send it out to the listserv right away. I know I sent out a lot of emails, so sorry about that, but I shared as soon as I heard it, and we also put it out on Facebook.
It's okay. Those emails are helpful.
So I will send that email right away. So that is a good opportunity. I also wanted to remind people that a lot of you may have new legislators. So January 1st is when, I think it's actually January 3rd, when the new legislature will take office. So it will be very important to check and see who your state senator and assembly representative are. They may have changed, and you should develop a relationship with them and offer to be a resource on mental health issues. We really need the legislature to step up and to engage on mental health. Our state has a big surplus, and those funds could be used to support mental health services. So you can count on the Mental Health Task Force. We will keep you posted in 2023 about the biennial budget process and how you can make your voice heard. So I think that's all we have time for now, and I will turn it back over to Mary to wrap us up for 2022. Can't believe the year is over.
I think we have 1 minute left. I just wanted to share that the Milwaukee County Mental Health Board will be going back to in-person meetings starting in January 2023. And our first meeting in January, and my calendar just fell on the floor and I can't reach it. I had surgery and I only have one arm and I'm in this funky chair. And it's a public comment meeting in January. And I believe it's the third Wednesday or third Thursday in January. We will get the date out, and it's at Washington Park Community Center. So it will be an in-person meeting. Wanted to share that with you. So on that note, remember our next task force meeting is January 10th, 2023, and it will be a follow-up content to the Karen Avery Forum. I'd like to thank all the agencies and individuals that have contributed to our membership campaign. and all of you that have come and participated this year to the task force, and wish all of you happy, healthy holidays, and look forward to seeing you all next year. Thank you very much.